Hello, welcome. My name is Dr. Shumim Badania from the Leadership Dialogue. In this webinar, I'd like to share with you the COVID-19 simulator for policymaking, CoSimPol, to walk you through the different components of the user interface. The actual simulator is available at this URL, but at this point, let me now go to the actual interface itself. And walk you through the major components. So this is the dashboard, the user interface, and I'll just walk you through the main components. So this section here, these sets of tabs, are all your inputs and essentially the major assumptions on which the model relies on. The key data that it relies on is in these four tabs here, and we'll look through that in a little bit more detail shortly. Here we have the output panel, and we have four tabs with different graphs representing the different aspects of the epidemic. Down here we have intervention possibilities, two possible lockdowns and the intensities. Here we have a switch that models whether we want to include the constraint on critical care beds. This is a little device that enables the user to show building bed capacity, the rate of building bed capacity. This knob represents the quality of in-hospital healthcare, and it drives a nonlinear relationship that has an impact on dying in hospital depending on the quality of in-hospital care using this knob, and it ranges from 1 to 10, 10 being excellent healthcare. Here we have the different stocks, the values of each of the different stocks as the simulation runs in each of the different categories. And this is your buttons, which is almost self-explanatory. That's to run the simulation. At any time, you can reset to your default conditions. The view model takes you to the high levels, just a graphic of the high level structure, just as a reminder. Return to the simulator there. Go live enables you to see the impact of changes immediately. So for example, if I go to lockdown draconian, you see it's phase shifted, and I do a second one. Let me do that. You start seeing here, you see that it's been shifted, and the two lockdowns. If I go there and go lockdown draconian there, look at that effect. Yeah, you see it better if I go into breakdowns. You'll see the impacts there. If I put in the switch for, can you see that's phase shifted there, or the quality of in-hospital care, changing that effects. Those effects there. Let's just try to do one to see, so you'll see. Let me do building rate, and I'm going to build. What's this orange line here? I'm going to build capacity, so you'll see, just as an experiment, you'll see the effect of. Can you see that the orange line has now increased? So that's basically the key elements. I'm now going to reset the simulation. If you click on assumptions, it will show you all the values used in the base case, and obviously one can critique those. If you have data for your setting that's different, you can change those values, and you can also use this to mediate between different experts and epidemiologists' perspectives, opinions, mediate between those to kind of check assumptions, check the hypotheses, critique it so that you can make the model more robust. All right, so let me return to the simulator and walk you through the input panel. So the key inputs, the initial population, I've set the base case to South Africa, number of new cases on the start day, number of known cases on the start day, so I've put in 6,336, which was about a week ago here in South Africa. And then the proportion of unknown cases to known cases, and quite often in some contexts, because of insufficient testing, etc., the actual cases are far higher than the known cases, and here the user is able to make some assumptions around that. Then there's the aspects of the epidemic itself in terms of the the best data we have available for each of these things. The user could change that. So incubation period, recovery time, hospital recovery time. These three input parameters, the vulnerable per thousand, so they set in per thousand, and vulnerable per thousand hospital represents the number of patients that are infected, that per thousand that would require hospitalization but not critical care. And the next one is that would require hospitalization, critical care, or ICU, ventilators, and so on. The ultra vulnerable per thousand represents the category of infected patients that require hospitalization or require critical care, but do not have the opportunity for hospitalization or critical care for a variety of reasons. Maybe they are severely immunosuppressed and they just can't be taken to hospital. They have, in the South African condition, we have large percentages of people with tuberculosis, with HIV/AIDS, and other comorbidities. And then we have issues around poverty and class, which means that healthcare access is not as straightforward and not as easy, and therefore there will be ultra vulnerable people who require hospitalization. They simply just do not have the opportunity to get it, and that obviously would impact the mortality rates. The infectivity and contact settings, these are the numbers together with the illness duration that will drive the R0 numbers and the effective R. Given that COVID-19 spreads not just through person-to-person contact, but also through contacts with surfaces that an infected person has been in touch with, and therefore the number of contacts, this represents per day, the number of, in this case, normal contacts per asymptomatic person per day, with that includes number of surfaces. So a healthy person coming into contact either with an asymptomatic person or a surface that has been touched by an asymptomatic person that could transmit the virus. And then there's the rate of infectivity. And I'm working with an R0 of 2.94, which there's a range of R0 figures that have been used. They range anything from 2 to 3.5, and I'm using an R0 of 2.94, and one could change that by changing these variables. Bed capacity includes the current hospital bed capacity, normal hospital beds, as well as critical care bed capacity. I've calibrated it for the South African conditions on data available. Obviously, one could as data becomes available, could change those numbers to make it more accurate. This represents available bed capacity, and I've not made a distinction between, so this represents available for COVID patients. So I've not taken into account bed capacity that's already used up by patients for other conditions, nor have I taken into any of the displacement effects of COVID-19. So that number might actually need to come down if we can estimate the number of beds that have already been taken up by people with other conditions. And I've not made a distinction between public and private healthcare facilities. I've just used an aggregate number, and again, one could elaborate the model to do that. This tab shows lockdowns, and essentially it enables the user to show the start day of a lockdown, the duration of a lockdown, and you can model up to 2 lockdowns. And here, if we go to the graphs, let me run the simulation now. The breakdown shows the trajectory over time as the epidemic spreads of the different categories in the different stocks. If you move your cursor along, you'll notice that it will show you on any given day each of the categories. So it'll give you, for example, here I'm sitting on day 109, and there's 4.26 million healthy people, 285,000 have recovered, etc. The inspection spread shows you the daily infections and the peak, and here you can see the peak is on day 53 roughly. So I was using last week's numbers, so that means on the base case we would expect the infection to peak in around the end of June in South Africa. That's without any interventions. Hospitalization, this shows the differences in terms of the available bed capacity and the hospital requirements. So if you look at the green, that's severe cases not hospitalized. That essentially models the number, shows you the number of beds required that's not available, that's going to lead to people dying because there's just not enough capacity. And critical care just parallels that. This is for critical care bed capacity as opposed to hospitalization capacity. Here we have a switch for critical bed care constraints. So you can choose to include the constraints or not. We've already looked at this as the building of bed capacity rates over time that the user can adopt. The NPI represents non-pharmaceutical interventions such as social distancing, the use of personal protective equipment, etc. And it's modeled as a nonlinear function, which again the user can change. The base case represents a 15% reduction in infectivity through NPI, non-pharmaceutical interventions, but that's based on a nonlinear decay function, because as time goes, people become more lax, and therefore the effectiveness of NPI will reduce. But once again, the user can change those assumptions. Okay, so here's our R naught prime value and our effective R number value as time progresses, and you can also see it on the graphs. This represents the stocks, the number of people in each of the stocks, and if I run the simulation, it will show you as it's changing, and this is the percentage relative to the total population. Assumptions takes us to the set of assumptions with the initial values that I'd shown earlier. So one could explore that and critique that, and based on the best data and the best scientific evidence available, one could change those assumptions. In fact, most of the input variables are available to be changed. There's a few that, for example, the percentage reduction in lockdown intensity, that's not, but based on requests, I could make that available. Go live. I think I've covered that already, but just very quickly, go live enables you to see the impacts immediately of any changes. And let's go to infection spread, and let's go to lockdown draconian. And you saw that was phase shifted. Let's put a second lockdown and make that 40 days. And see that for duration of 40 days. See that there, if I put it on draconian 2. There you see, now you see the effect of both the lockdowns. Reset the simulations, resets the, excuse me, the model to its defaults, and then you can run the simulation again. When you use go live, notice immediately I changed the NPI switch, the deaths dropped. Watch that. To start off at 174,000, with NPI we now have deaths of 112,000. So go live shows you the effects of your changes immediately. At any point you can stop live, and that means when you make changes, you can make several changes, and then you run the simulation again to see the impacts of those changes, like you see here on this blue curve. So that gives you a rough sense of the overall user interface. In a future webinar, I will then start running some scenarios that you can then explore, and we'll see the impacts of, for example, lockdowns or bed capacity, etc. Thank you very much. Please, if you find this useful, please share it with your colleagues. Familiarize yourself with the dashboard. Look at the CoSimPol introductory webinar where I walk you through the underlying structure and the purpose of the model. So you need to look at these webinars in conjunction with each other. Thank you very much, and see you next time.